We all have our ups and downs, but the ups and downs for people with bipolar disorder are more extreme and, if untreated, can have a significant impact on day-to-day life. A panel of experts takes your questions about bipolar disorder. Next on Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center, and tonight we're taking your questions on bipolar disorder. As always, we depend on questions from viewers, that's you, to help explore this issue. Now, we know you've had a good, long, and restful holiday, but it is time to get back to work, so call the numbers on your screen right now locally. Dial 218-788-2844 or call toll-free at 1-877-307-8762. You can also text us your questions or email them using the number or address listed at the bottom of your screen. You have all kinds of options. There's no excuses. We're expecting lots and lots of questions rolling in after this long break that we've had. We're going to start, though, of course, by introducing our guest tonight. Dr. Steve Bauer is the medical director at the Human Development Center. He's board certified in child, adolescent, and adult psychiatry. Julie Wilson is the Human Development Center's Director of Community Support Programs for Carlton and St. Louis counties. For over 30 years, she's worked with adults with serious and persistent mental illnesses, including bipolar disorder. And Julie Roppy-Stern has worked in a variety of capacities for Arrowhead Regional Corrections for the past 28 years, often working with offenders with mental health and chemical dependency problems. She's the vice president of the Duluth chapter of the National Alliance on Mental Illness, known as NAMI, and comes to us tonight to share her experience of being a mother with a daughter with bipolar disorder. Thanks to all of you for coming here. We've got Julie, and I just really wish you were Dr. Julie tonight. You didn't get that memo.
I did not.
And your middle name isn't Jules by any chance?
Well, it starts with a J, but that's
close.
Yep.
Close. And we're going to start with you because I think, I always love getting the audience on the same page with us. And so let's start by having you tell us, what is bipolar disorder?
Well, all of our mental health disorders are characterized by having a series of symptoms. And so bipolar is the combination of having a major depression along with what's referred to as mania. Major depression has 9 symptoms that we look for: sleep problems, appetite problems, energy problems, concentration problems, crying for no reason, crabby over nothing, hopelessness, helplessness, suicidal thinking, lack of interest in your usual activities. And then mania is the opposite. So mania is not sleeping much, not having too much energy, not being able to keep your ideas organized because you have so much energy, and characteristic is usually grandiosity, that is, being so full of oneself that you believe everything you think or everything that's going on is the greatest ever. And the big thing that separates it from lots of people is that it's very different than how you are normally. So you have these episodes of either being down or too up, as well as being in the middle to some degree. Now, we used to say that people were normal in the middle. There are people now who talk a lot about having chronic depression as part of this illness as well. So there are lots of phases, and bipolar has extended phases for it to be more classic.
And there are also different flavors of bipolar disorder as well, right?
Yeah.
Where you can have somebody with a major depression and maybe more a hypomania, not just the mania.
Very true. Something called cyclothymia is a variant of this. As you called them flavors, that's a nice way to put it. We've done a lot of research, and people have, to some degree, confused this issue to a great degree by coming up with all kinds of different names for it. And if you really look at it on a continuum, where bipolar is really having just these mood cycles, and then on the other end of the continuum is schizophrenia, which we talked about the last time I was here. There is a center area where you can have periods of psychosis that, if they're just when you're having mood symptoms, we see that as bipolar with psychotic features, versus you have the mood cycles and you have psychosis when you're not in a mood cycle. That's something called schizoaffective disorder. But rapid cycling, mood incongruent, there are lots of ways of talking about the flavor being slightly more or less in these areas, and it confuses a lot of people.
And speaking of confusing a lot of people, talk about the diagnosis of bipolar disorder in children and adolescents and how that's a little different sometimes than diagnosing an adult.
Yes, you're absolutely right. The child and adolescent issue is one that has kind of swung to both ends of the pendulum. When I started training, it was extremely rare for anyone under the age of 15 to show any of these extended mood cycles. And then we got into kind of a debate amongst ourselves over the idea of people who had extreme temper tantrums and the frequency with temper tantrums and how much that would then lead someone to be in an altered mood. And people started using very intense medicines in kids, and the jury remains somewhat out, but I think we've kind of swung back from the extreme of calling lots of mood things, or excuse me, lots of tantrums mood things, and I think people are now trying to differentiate that again, and I think the next diagnostic and statistical manual will reflect that there is a group of kids with severe tantrums that have not met the criteria for bipolar.
And I bring up the diagnosing of bipolar disorder in kids and adolescents because, of course, you have a daughter who was diagnosed with bipolar disorder. And tell us about what your experience of that was as a mother, and just kind of the progression of that, how you came to see that maybe things weren't quite right.
Well, Whitney's symptoms started about 6th, 7th grade, right in there. And what we noticed was she seemed to have a lot of anxiety in social situations and was not feeling comfortable sort of in her own skin, that type of thing. And not like she was terribly depressed or anything, but she just wasn't feeling easy with social situations, very, very uncomfortable, that kind of thing. So what we did was, at some point, her father was diagnosed bipolar, as well as her grandfather. Back then it was called manic depression. So, I was a little concerned, and I, at one point, said, if you ever think you want to talk to somebody about that, because she was kind of bringing some things up and saying, well, I'm afraid I might not be able to do all the things that I want to do, because she was feeling those limitations. She was experiencing those limitations. And so I said, well, if you ever want to talk to someone, just let me know, because we'll get you in to see somebody. And about 3 weeks later, she said, Mom, I think I really should go in and talk to someone. So we got her in right away. We're fortunate. We had good health insurance, all that good stuff, and got her in right away to talk to a therapist. And she also was with a psychiatrist as well, who was very, very good for her and listened to her, that kind of thing. And it was really scary at first. She wasn't diagnosed bipolar immediately, but we knew she had, at the very least, some pretty excessive anxiety, especially in social situations.
And that can be really common for kids first having, first experiencing anxiety, being diagnosed with an anxiety disorder, maybe ADHD, and then as time goes on, the symptom pattern begins to emerge a little bit more clearly as well, and we can see maybe what the true diagnosis is, which is what kind of sounds like happened with Whitney. Is that?
Well, that's exactly what happened. They just didn't have the exact criteria to diagnose her with bipolar, and I can't even remember what age it was exactly then that they said, yeah, she was then, because they knew that she had had one manic episode. I believe it was in her late teens. And so, you know, there wasn't the exact criteria, but, you know, they kind of labeled her with social anxiety, some other things I can't remember right now, but and then later on we were told, yeah, she does have bipolar. So.
And I want to come back to you and ask you a couple more experience about what it was like being a mom in that situation. But first I'm going to go to you, Julie number 2. And I feel like this is Julie number 1 and Julie number 2 and not Julie and not Dr. Julie. You see primarily adults, and often many times adults who have not had perhaps the benefit of early diagnosis and early intervention. Tell us a little bit about who you often wind up working with, Julie.
Sure. Many times the individuals that come to see us in our community support program have had the illness for quite a long time. Many have been undiagnosed, and we see a lot of folks that are in their 30s and 40s. They may not have had the adequate treatment. They may not even have a psychiatrist. And so we start, you know, with an assessment and looking at the whole picture, you know, what's going on with them. Many of these folks do not have any support systems. They've been isolated from family. Family have, they've been through a lot with these people. Many of them are homeless. And so it's a wide variety of people that we see. And they have many needs because they don't have the structure that they may have had if they had been diagnosed earlier or been within a family situation that was supportive.
You all are doing a bang-up job out there of getting us questions, so I think we better go to some of these questions. Dr. Bauer, somebody from Duluth calls in and asks, what are the causes of bipolar disorder?
Great question. There are several syndromes that we know are associated with bipolar. So people who suffer from migraines or have had head injuries are at a much higher risk of having bipolar. Certainly families, we know that there are some families where this seems to run in it, though sometimes you get the entire picture or sometimes you just get depression or you might have some other piece, and the complication of genetics remains more to be unraveled yet. There's a lot that we don't understand, but we know it runs in families. So those are a couple. Certainly people have talked about seizure disorders and its connection because we use seizure medicines as one of the mood stabilizers. And so there was a theory of kindling, we called it, that was a subsyndromal seizure. And by using these medicines, you could settle that down. There's probably multiple causes and certainly different things that occur within lifestyle, and particularly chemical dependency, that can coexist with this, become big parts of how bad it becomes and how long before it gets under control, if you can get it under control.
So much like heart disease, where you can have genetic risk factors, but you can also have individual biological factors, and then you can have some other just lifestyle issues that can trigger off an episode of bipolar disorder as well then.
Very much so.
Let's go back to you now, Julie. So you're a mother, and you have just heard that your daughter's been diagnosed with bipolar disorder. And tell us what that's like, what that was like for you as a parent.
That was very, very scary. Because I didn't at the time know as much as I know now about bipolar. And I didn't know that some people live well with bipolar. I didn't know that. The people I'd known hadn't fared very well and had combined chemicals with it and those kinds of things. And so that was, I think, what scared me is, you know, how was she going to do? And was there any hope even? She's such a bright girl and wanted to do so many things. And so it was just, that moment was horrifying. But then, you know, I just had to pick myself up and say, you know, she's not dying. She hasn't been given a death sentence. And
that there are worse diagnoses that you as a mother could have been hearing, actually.
That's what I had to tell myself. That was just the way I dealt with it, that there was help out there, and that we were going to do everything we could to get her the proper care that she needed. She hadn't, she's not a person who has ever used chemicals, drugs, illegal drugs, or alcohol even. She just doesn't care to. That isn't something she's interested in. So that was really helpful, that we didn't have to worry about that piece. Working in corrections, that's what I see a lot is, people who probably, like you said, Julie, were undiagnosed, but started experiencing symptoms from the age of 14 or 15 and immediately started using drugs or alcohol to feel better. And they didn't find out until 6-7 years later that actually they have this thing called bipolar. And now you've got two problems. You've got a chemical dependency problem and a mental health issue going on. So it gets really difficult, I think, to then try to separate those two issues, and then you have to deal with them both.
And in fact, in my own experience in my practice is that people often come to mental health or law enforcement attention through their chemical use, and they've been undiagnosed with bipolar disorder, and they get sober, and it's like, oh, you're still having some problems here. We can more clearly see, where people talk about using alcohol and drugs to medicate the symptoms. I'm sure you must have seen that in your practice as well.
I have.
And you as well.
Definitely. Yeah, it's a big issue. I think the last 20 years we've seen an increase in the self-medication, and it becomes difficult at times to treat both, but we do have to treat them both at the same time and figure out, where are we going with this individual. So we have to address the chemical health and the bipolar disorder in order to work with this individual.
Now, Julie 1 brought up that one of your concerns was that you had only seen people who were very ill in their illness, and you hadn't seen people be able to live really very rich and full lives, and that was one of the things that scared you as a parent. And one of the things that we see with bipolar disorder is that there, sort of similar to diabetes maybe, is that there is a range of from quite very, very severe to less severe in terms of if you're getting adequate treatment for that. Talk a little bit about this, and then afterwards we'll have you comment on that.
Well, and I think it's very appropriate maybe the other way around, and yet certainly what we know, people's premorbid function, and so if they're doing well in school and they have an intact family and they have insurance and other things to seek help and they have the inclination to seek help, those are all things that lead to a more successful outcome in treatment. Quite often people are not wanting to think in those terms, be it the parents, be it the individual themselves, and those things interfere with where you're going. By the time you wind up with homelessness and chemical dependency, there are so many factors that are now swirling about. The severity of the likelihood that they look like they're functioning is much less. And that's where, having ARMS to help support and help get housing.
ARMS is Adult Rehabilitative Mental Health Services.
Thank you. I'm glad you did that. So I like to refer to the acronym and move on.
We don't do that here in TV land. No.
All right. So long and the short, I think the analogy of diabetes is very good. Less than 15% of people with diabetes have what is seen as a good outcome, meaning they don't wind up with some of the side effect of not having your blood sugar regulated. Most of those are very severe medical things like becoming blind or having your kidneys fail. And unfortunately, people with severe and persistent mental health problems have the lowest life expectancy of any of us because of the combination of lifestyle and maybe some of the things that the medicines do to try to help, and then hard lives. So
let's talk about, given that shortened lifespan, what are some coping skills, Julie, that people can use, and that, in fact, these ARMS workers, and maybe you can also explain then exactly how ARMS workers help people with bipolar disorder.
Adult Rehabilitative Mental Health Services is we have various providers in the St. Louis County area right now. And what we work on is illness and recovery and helping an individual learn how to manage their illness. And so some of the coping skills is teaching someone how to manage stress. Stress is a huge impact on symptoms and can really increase the severity of their illness. We try to develop structure. Many people don't have structure in their life anymore. We need to work really hard on stabilizing them, finding them psychiatry. But some of the other coping skills is just learning about your illness and instilling hope and practicing those skills over and over. So we really are coaches for these individuals. Not that we've all experienced it, but many of us have a lot of experience in working with individuals, so we coach them along. We help them, we role play, we hook them up with other services, other people that have had the illness. And so it's about instilling hope and then just practicing those skills.
And I think that's so important, and I think a real message that we want to get out tonight is that regardless of where your illness is, you can have a meaningful life that is purposeful to you and that is satisfying to you. Whether you're Whitney, who is very high functioning, or whether you are somebody with a more severe disorder, like the people who you work with. There's a caller from Danelle, or an email. I love that. We got an email from Danelle, and Julie Rappi, I think I'll direct this to you as a parent. What helps or hinders your adult child who has recently been diagnosed with bipolar disorder? And you have an affiliation with NAMI as well, so.
Yes. What hinders?
Or helps.
Or helps. An adult child. I see a lot of people who, stigma's at the top of the list.
For hindering. It is.
Because people are so afraid to talk about it or admit it because they think that other people won't accept them, or they'll, won't like them, or that they'll think they're weird. Or I was talking with a client today who said, he just thought people would think he was weird, so he didn't tell anybody, he didn't tell his own mother. And his symptoms started at age 15. So stigma is huge for hindering. We have a big problem in that not everybody has health insurance to be able to go and seek that help. So that's a problem. But just support. And NAMI is a National Alliance on Mental Illness, is a very good organization. They have free meetings and things that people can just go get some education, get some support, just talk with other people who are experiencing what they're experiencing, whether you're the person with the mental illness or a family member, a loved one, who just wants to understand more. And they see people openly talking about it, just like you and I might sit down and talk about diabetes, and they have never been able to do that before.
And that's what I love about NAMI, is that both the person with the illness and the friends and family members can go.
Exactly.
And that there are programs and there are services for all of those people, not just for the person with the illness.
Exactly.
Dr. Bauer, a caller calls in, do symptoms of bipolar get worse as you get older? And I like this question because we had a show earlier with Dr. Miller and Kathy Cox on about talking about mental illness in geriatric patients. And so?
Well, theoretically, there are folks who feel like bipolar will burn out as you age. And so in your 40s or 50s, theoretically, symptoms slow up. But Dr. Miller and Kathy and I have all seen patients who are still going strong in their 70s and 80s.
So again, the picture is going to vary with the individual.
Very much so.
On that. What are some of the most significant treatments or interventions that have been beneficial? Let's start with you, Julie, on that one.
Well, I think in the program that I work in and when we're working with individuals is teaching, first of all, stabilization with medications if that's necessary, and really working close with that individual. If they're seeing a psychiatrist or a primary doctor and they're on medications, one of the things that we do is really talk about that with them and help them advocate with their psychiatrist, because sometimes they just don't really know how to articulate what symptom is being treated by this and what is being helped by that. The other thing is really helping them identify triggers. to either a manic episode, maybe they're getting revved up, or a depressed episode. So we do relapse prevention plans, and I think those are our treatments that we do. We do a lot of coping and teaching about skills. So,
and I think that's a wonderful place to stop, because we are out of time for this show. You all did a bang-up job. You did your homework of calling in, so you're going to want to tune into my blog. That'll get out there, and you know who's going to get that out? That's going to be Whitney. This show is dedicated to Whitney. She is our intern. She's a fabulous young woman. We love her here. Don't forget to visit us on the web at speakyourmindonline.org. That's where you find the blog and the list of our topics and resource links. I'm going to be answering all of those questions. Check us out on Facebook, too, and let us know what your New Year's resolutions are. Mine are to lead a balanced life. I hear I'm not doing so well at that already. Please tune in for next week's show when we talk about infants' attachment and bonding and the impact of postpartum depression on both the mother and her baby. I'm Dr. Carolyn Phelps. Thanks for watching, and good night.